Folks, if you would, come on in and we'll close that back door back there, please. Any of you that are standing, if you want to sit in some of these seats in the back, that'll be fine. You okay? Okay. Okay, I'm going to call our Health Subcommittee of Appropriations to order, and we'll begin moving along. Like I said, anybody wants to get a seat toward the back, there's some extra seats. Feel free to make yourself comfortable. Glad to have you. Purpose of our meeting today is to hear from our agencies regarding our FY21 budget, and since it's Public Health Day at the Capitol, we thought we ought to start with all our public health folks. So Dr. Toomey, come up and share some information with us. We're glad to have you.
I know you're going to find this, Mr. Chairman, hard to believe that it's a pleasure to be here today, but believe it or not, since I last saw you, I've been working 24/7 on coronavirus. So it is a good distraction for me to refocus back on our core work. And I also want to point out that many of our health directors who were here with me this morning are here in the hearing room, and I really welcome the opportunity for them to have a chance to comment if you have specific questions for them as well. We're really privileged to have them here as part of Public Health Day. I know I really ran through the slides pretty quickly at the first hearing. I want to just emphasize again, as Public Health Day, that we are working together with transparency as a team, and I think that is the message I tried to convey when I introduced the health directors this morning. And so this budget represents that effort to work together with them as well as our leadership to minimize the adverse impact of cuts. It's never easy to take reductions at any time, but we're trying to minimize the impact of these reductions throughout the state. So not just the state office, but throughout all parts of the public health system. I wanted to also, because I kind of ran through this very quickly, to kind of revisit what our public health priorities are, because that also helps explain what some of the reductions were and what some of them weren't. We went through the data, we looked at the statistics, we went through the programs, and it was very clear to us that maternal mortality and addressing those challenges had to be a top priority of public health. And that will involve a lot of probably new and innovative work for us, including collaborations with the medical community. We have to do better in infant mortality and morbidity. That's we're again one of the at the bottom of the heap there as well. And last but not least, the HIV prevention and care has to be a priority for us. When you look at us in the city of Atlanta, we have the highest rates in the country. For that reason, CDC has identified the metro area as and the HIV epidemic epicenter. But we also recognize that many parts of Georgia, including Dougherty County, Muskogee County, other parts of Georgia, rural Georgia, have rates as high as Fulton. It's just that the numbers are not as high. And that we need to have a statewide effort to end HIV in Georgia. And so this reflects some of the thinking that we had to take into account as we looked at where reductions are being proposed on the budget. I also wanted to reinforce the fact that we are not a personnel-heavy agency. Only 13% of our total budget are in staff. The majority of our funds, both federal and state funds, are in direct services, and those direct services include federally funded programs such as WIC and Ryan White, the HIV treatment program, as well as the grants to counties, programmatic as well as general grant and aid. And finally, looking at the appropriations, breaking it out into state and federal funds, you can see that, as I mentioned earlier, the good news and the bad news is that 60% of our budget is federal, so that this budget reduction affects about 40% of our total funding. However, almost 46% of our state funding is the grant and aid. And so it's such a huge proportion of our state funding, it's difficult for us to look at any reduction in our state funding without at least taking into account some consideration of a grant and aid reduction. The other thing that we took into account is that federal funds, and many of them, in fact, most of them go to the district and counties, and these include WIC, tuberculosis, all the CDC funds like breast and cervical cancer, require maintenance of efforts and state match. And so we worked very diligently to try to ensure that we weren't going to reduce any of our federal funds at the same time we were looking at state funds. So that is all kind of way as background to looking at a line-by-line look at our budget reductions for 2021. I mentioned, and I will mention again, that we had identified when I began some fiscal challenges that were not apparent initially, and we, even before we got our budget instructions, we institute travel restrictions and also critical hiring process. And so you'll see throughout this budget reductions for travel, savings from travel, savings from salary savings for hiring personnel, and that reflects that work that actually was initiated even prior to the development of this budget. And as I did the last time, and I hope it won't be too odious, because we cut in such a careful way and took reductions that in a way that would minimize impact. There's many lines of reductions, and so I will try to quickly go through all of the lines, and we'll take questions either during or after, whatever is best for you. We have, throughout our budget lines, we have a reduction because of the Georgia Tech Authority gets contract. That contract reflects, our reimbursement or our payments to GTA, and that will be consistent throughout our programs. We got an increase in funds to provide a pay raise to full-time eligible employees with current salaries of $40,000 or less. You're going to ask me how many of those we have, and I'm not able to give you that number today, and I'll certainly work on getting that to you if that is some information you would like to have. A reduction that I know is painful is we reduced funds for 5 Coverdale Murphy remote stroke readiness grants, and so this does not affect the current 19 stroke centers that we have in place. It affects the purchase of new telehealth equipment for new hospitals coming on board. So again, I want to emphasize the fact that the system, the stroke system is in place, but the additional 5 will not be added with this reduction. We had some contractual services, including the SHAPE grant, which is an obesity grant that we had been using state funds to pay. We were able to use federal funds to pick that up, and some other contractual service around the nurse peer program, which leaves about $50,000 to continue to do some training and education in that area. I know there's another grant that's of concern, is the reductions to the Sickle Cell Foundation. we will be using $45,000 of federal monies to offset some of these reductions. And so what is remaining of those reductions are no direct services. I think 150 individuals or more will still continue to have case management under the under this contract. But what it does eliminate are some health fairs and some patient education that were planned with those additional funds. The Georgia Corps is a cancer prevention organization that works with the regional cancer coalitions. This reduction is higher than the reduction that was taken in last year's budget. And it leaves for both the Corps and the coalitions about $2.4 million. And we didn't recommend that this be divided equally, or that decision of how to make those reductions would be left up to, I think, discussions and negotiations as we move forward. We wanted to look at the Maternal and Child Health Services Block Grant to pick up a position that was currently being used with state funds for maternal depression, again, one of our priorities. So we don't want to reduce that. Federal funds from the block grant can pick up that position and pay to continue that support for that program. And you'll be seeing this again and again. I won't repeat it. I'll just say travel, funds for travel and training, as I noted earlier in the discussion. And then there was one vacant position in chronic disease. We were able to reorg that section and reduce that without impact in services. And so moving on to the Departmental Admin, which a lot of these reductions and adds represent statewide adjustments. And so I think you've seen these before in other areas. The reduction to in the employee share of the teachers' retirement system, an adjustment to the cybersecurity insurance premiums for DOAS, a reduction for the tech authority, as was noted previously, and each of our programs will have that reduction. That increase in funds to pay for the staff making $40,000 or less. Some contractual services reduction, and this is actually a new one that you may not have seen, and this was the Public Health Information Portal. We could, for reasons that are unclear historically, we had that contracted out to somebody in Michigan answering data queries to our epi and data people at the state. We will bring that in-house. It will be more efficient, more effective, and more responsive. So this is a very good thing. We are reducing 14 vacant positions, and many of these positions are in the office of the director, the chief of staff, budget, fiscal ITs, many support staff vacant, so there's no reduction in force. We reduced funds to consolidate 2 district health director positions. This is something that came up at the larger meeting a few weeks ago. The most affected district would be Clayton. I don't know, Dr. Obasanjo, who's the health director who is working with me on that, will be here later and can answer questions. We have actually already met with the Clayton delegation to explain what we're doing and why, and I think we've been able to address their concerns, and I feel very good about that. And I as I mentioned earlier, I feel that we can actually improve the delivery of services under this change in structure and some of the organizational changes that will result. And last is that you may remember when the Fulton County Board of Health was thankfully created a few years ago. Money was put into the budget for the district cadre, but it was put in the wrong pot of money, basically. It was put in grant aid instead of into admin, which it should have been, because district cadre is actually part of the admin budget. And so this just moves this into the appropriate slot. So it's not really an add to Fulton, but it moves it out of the grant and aid pot of money, which would make it subject to reductions. On the emergency preparedness and trauma system improvement, this is again travel reductions as well as the other funding reductions for GETS and the pay raise increase, the teachers' retirement system. We were able to realize some travel savings from that directive from our office, and that's out of the injury program. In epidemiology, which is a critical part of our work, we again have those same reductions, the tech authority, the funds for pay raise. We thought we could reduce the hepatitis C test kits. It was a 30% reduction in the total amount of funding for that without significantly affecting our ability to test. And so there's still 1,700 test kits available for the districts to use for testing as opposed to about 21 or 2,200. And the other key point is that an epidemiologist whose full-time job is Hep C, hepatitis epidemiologist, and some operational monies also remain. So we thought this could be absorbed without limiting services. The Poison Center reduction is one that I talked about a little bit last time because it actually doesn't reflect the actual requested reduction. We had hoped that in efforts to improve efficiency and effectiveness, just like we were trying to do statewide, the Poison Center could absorb a $49,000 cut. That's out of a $1.2 million total contract. But the additional funds that you see there as a reduction, one is $40,000 for a consultant, which is no longer needed in epidemiology, so that can be reduced without any impact. And a temporary service worker, again, who can be, the position can be eliminated, and that's about $64,590. So just to reinforce the fact that the Poison Center was not reduced that much money, the actual amount of proposed reduction was the same as in the FY20 budget. On immunizations, we were able to find some additional monies because we in going through this process, we actually came to realize that immunization monies were paying for an IT position in WIC. Now, WIC, a fully federally funded program, we saw an opportunity to have WIC pick up the funding for that IT position, and that allowed us to free up about $109,445. And then again, travel and supplies, the recurring theme that reflects the work that we did early on and after the proposed budget was moved forward. Infant and child essential health treatment services is a long list of items. It includes the teacher retirement system reduction, the reduction for the GETS contract, the pay raise for the 40,000 or less employees. We had some money left over from the WIC settlement. I don't know if you remember, a number of years ago, we had some problems with WIC and had to pay back the federal dollars, and we had to get state dollars to do that. This was left over from that settlement. We are okay with the feds at this point, and so we were able to use that to redirect it to our proposed reductions. We have increased funds to reflect a reduction in the federal medical assistant percentage of the FMAP program, and the Maternal and Child Health Block Grant, which funds can be used legally to fund the CMS program. The Children's Medical Services Program provides care and direct service to specialty care for children with disabilities of various kinds. And so we were able to basically do a fund source swap, as we call it, and use federal dollars to pay for that. The reduction in the contractual services represents a reduction of $55,000 in a contract with Emory that included some training for autism. My understanding from the program is that training in the way it was done was no longer needed at this time, would not impact any autism services, and there's still $45,000 remaining in the contract. We really worked hard to ensure that no services were reduced, and this had to do with training that the districts were doing, and many of the staff had been trained. Infant and child health promotion reflects, again, the GETS, the pay raise, some contractual services. This is a $40,000 reduction to the Marcus Center. The Marcus Center total contract has about $310,000 remaining. We're not cutting autism services at all, and I know that this is of concern to many of you. This was a patient navigator that individuals were trained on, and what I've been told by the program is no longer going to be used by new providers. And so, again, the impact of reducing this navigator tool would not impact ongoing services. And we had a health check nurse position in a reorganization that was no longer needed, and we're able to reduce one position, $130,000. Moving on to infectious disease control, again, the same mantra of tech authority reductions, increased funds for the pay raise, travel and supply reduction. We were able to take $275,000 that was in our STD budget, our sexually transmitted diseases budget, for drugs. And I know several of you are pharmacists, and you're going to wonder, why didn't we use these? And for reasons that are unclear to me, when we explored it, these funds lapsed almost every year. And so we saw that we could safely reduce this amount in these purchase orders without reducing services, and use our federal and federal, both HIV and STD funds, to pick up the difference. And we vow that will never happen again, that we'll have money sitting on the table that isn't being spent, that could be going to services. And last, there are 4 vacant positions. 3 were in the STD program. The 3 were just unfilled. These can be picked up both by federal HIV and STD funds to do that work. We won't be diminishing any of the intensity of our work in these areas. And we have actually stopped doing parasitology at our laboratory. Our laboratory just felt that the volume was not there to justify maintaining a position and the overhead for that. We have plenty of work to do in the lab, including soon coronavirus. So this is the elimination of one position plus some operations for parasitology, and that individual will go into another position at the laboratory. For inspections, environmental hazards, this is a little complicated, and I mentioned this the last time. In addition to the GETS reduction, we had proposed 3 vacant positions be reduced for the salary savings in the 2020 budget, but that was perhaps inadvertently carried over into this budget year. Those positions are thankfully filled because they include two environmentalists, one in Muskogee, one in Albany, as well as our state environmental director. And so we will have to identify a substitute salary savings or some other savings. We may end up taking a programmatic savings to make that up. So we haven't been able to identify that area yet to make up this difference. Office of Children and Families is going to be changed, and this was actually what was left of this office was a series of contracts largely directed to early brain work. We have seen the opportunity to redirect our intensity of that work into all of our MCH programs. We can have broader reach, more sustainability, and actually reach every child that we touch through that work. And this is something that we've talked to the health directors about. This is something I've met with many of the providers about. And I think that particularly as we are able to include this work in Babies Can't Wait and home visitation and the other evidence-based programming we're doing throughout the counties, it'll actually enhance the impact of this work and allow it to be sustained. Now, the moment I have not been waiting for, and particularly with the health directors in the back, is the reduction to the grants to counties. I just want to say a couple of things. You've heard me say it before. First, and perhaps most important, we have been very transparent about what's been happening. We have let the health directors know as soon as we knew that there were going to be reductions, so that they could make adjustments as necessary to address these areas of reductions. And I know particularly for rural counties, this is a harder hit than, say, for a place like Gwinnett or even Fulton or DeKalb. They have lots of restaurants that have inspections, and you can keep that inspection money, or lots of other services or fees, or see lots of patients. Your one nurse health department may not have the same flexibility to adjust this. One of the things that we felt was very important is we did not in any way cut programmatic grant and aid. This is just a reduction to the general grant and aid, which has the most flexibility, which allows the health directors the most leeway, to make adjustments to their district as a whole. But those programs that you've come to expect at your local health department, no matter how big or how small, are funded through programmatic grant and aid, both federal and state, and that is intact. And so I wanted to reassure you about that. And I with the health directors in the back, I welcome you to ask them. They won't say they're happy, but they can't say that I haven't been transparent about what we're doing. Last, I wanted to, there was a reorganization in Vital Records, which allowed us to eliminate a position. That's $129,598, and that's the totality of our proposed budget reductions. And I'm happy to answer questions.
We've got a couple for you. Representative Petrie has a question.
Thank you, Mr. Chairman, and thank you, Commissioner. Had a question here for you. So you did a very good job explaining. So most of our regular programs that most of us here would expect are being done in our local county health departments are not going to be impacted by this $9.2 million. Can you help us to better understand what those services at the end of the day would look like? Can you give us the breadth of the type of cuts, that $9.2 million spread over our different county boards of health? What types of things are we talking about being cut here by the loss of these funds? I want to understand that better. And
it will, because there's so much flexibility in how the health director, and that's, I mean, it was not planned that they would be here today. It just happened. But I think when you talk to them, it's going to vary. Your Dublin health director is going to be different than your Savannah health director, different than your Gwinnett health director, and how they absorb this. It could be they leave some positions open and pick up the work with the existing positions for a time to get that salary savings to make up the difference. But that in many cases will be able to be done without reduction in services. They may stagger times for the staff are working so that there's coverage during the full amount of time, although they may not be able to have a full cadre of staff. But the intent was to give maximum flexibility and to not reduce the programs like immunizations and breast and cervical cancer, women's health that you've come to expect.
So I want to make sure I'm understanding, and I understand you can't give me any because there's a great deal of flexibility with each local director of their particular board. But can you give us some I mean, I think you're telling me it's really going to impact more staffing than services. Is that fair?
It depends on what they use their general grant and aid for. And I would suspect that it's more for some staffing, and there's flexibility about how they can do that. And as I said, a position that's vacant now may be left vacant for a little longer in order to make up that reduction. Remember that these reductions actually went into place for this calendar year already, and so that work has already been done to try to make up that budget. So these reductions have been ongoing since the beginning of 2020 budget year, October of this budget year. I would say I was a health director in Fulton. What I would have done in Fulton is leave vacant one of my leadership positions, but ensure that the people who were delivering the services were hired. That's what I would have done.
That's a good example of what I'm looking for. What would you have done in your previous role? That's a good way to describe what I'm trying to get at.
So absolutely trying to ensure that the people who are actually delivering services and providing leadership, they have enough guidance, but they're not working, but that you're not diminishing the number of people who actually provide direct service.
But at the end of the day, you're suggesting that people are going to get the services that they need. No one, is it fair to say that the services that we're providing in these local communities are still going to be available, regardless of the impact to the department? That's
what I'm saying, and again, I am really counting on their leadership to help me to ensure this happens, because the programmatic grant and aid is not going to be reduced. The programmatic grant and aid will continue. Those are the funds that are being used to deliver the programs. But there may be some leadership positions. There may be some other things that in Fulton we used grant and aid money to do some things for staff, extra things for staff. Well, this isn't the year to be having, staff all hands meetings with, we're going to be using grant and aid to pay for that. And I can't speak for Fulton now. I'm no longer over Fulton, but that's the sort of thing I would look for. Where can we eliminate some travel? Where can we, do we really need to send 4 people to that meeting? Can we send 1 person? Can we use our tele network? Every one of our counties, 159 counties, has a tele network. Can we use that to have a statewide meeting instead of all meeting in Atlanta at considerable cost for travel and hotel? And that's the kind of thing that we're looking at.
Okay. Thank you, Commissioner.
Toomey, the food establishments are inspected by the local health department, correct? Under the current situation that we have, how often are they inspected?
They should be inspected twice a year.
Okay.
And my understanding is that doesn't always happen, and it may be because of lack of sufficient staff or some other issues, but it should be twice a year.
All right, so it should be twice a year now, and we may be doing that or may not be doing that.
This grant and aid reduction should not in any way affect that, because the environmental health funds were not reduced, and the environmental health program itself generates funds from these inspections.
So if we take this cut, we're going to have less people, but we're still going to inspect it the same number of times. I'll turn to some of my health directors. My understanding is our environmental health
program is not necessarily funded out of grant and aid. Dr. Arona, do you want to comment?
Yes, the fees are generated for,
Dr. Arona is our Gwinnett Rockdale Newton Health Director, and as I mentioned, has the unfortunate job of being liaison for the health directors during this time.
Thank you so much, and I'm honored to be in your presence, Chairman and the committee. Our environmental health staff will not be reduced for this. If the staff is affected at all, it would be district level positions. And more specifically, to answer your question, Representative, we had a couple clinic administrator positions that were vacant due to attrition. And we held those, and like Dr. Toomey said, we've known about this all year and instituted these changes since October. And so it's always difficult, but what we do is we just try to spread out those responsibilities among district staff. Like the district nurses would cover those clinic administrative duties during that time. So, but I think it's been, the state's position as well as the counties all working together just to try to make sure we don't change any service. Is that the, direct patient services?
Thank you, Madam, for addressing my concern. I think that's kind of where I'm getting at. So, my mind works private sector as an entrepreneur and a business person. And so it sounds like what I'm hearing is that we're not impacting individuals served in the community that we need to serve. It's more about maybe some of the staff, maybe some people are losing their jobs, or maybe vague positions we're not filling. That doesn't concern me so much. And I'll tell you why, because we got the lowest unemployment in history. So there's a job for everybody today. So I'm not as concerned about that. I'm concerned about whether people are getting, the people that need these services are getting those services. That's what I want to know. I want to know that we're not cutting things that are important to the population we serve more broadly. That's more important. Because if this position's not filled or another, there's plenty of people trying to hire those folks. Okay?
Right.
We all know that. So that's what I'm trying to understand. Thank you.
Yes, sir.
Thank you, Mr. Chairman. My concern is also about the health department. I come from rural communities.
Yes.
And two things. One, ours is so diverse. I know the health department does many things. As a matter of fact, we have a meeting coming up for disaster recovery. We had Hurricane Michael last year, and they were an integral part of it.
That's right.
We need to make sure those services are available, and how thin can you spread it? But as I look and I'm listening to what's happening, how are you determining how you're going to distribute the money? Is it based on population? Is it based on the services that they're supplying? Some of mine do hands-on patient care. They give immunizations. They do those type of things. We have some that work with our expectant mothers. They get them enrolled. They get them where they need to be. I don't know what every health department does. I only know some of what my own do. So I'm concerned on how you're going to determine what amount of money goes where.
That's actually an easy answer for me to say, because the programmatic grant and aid is determined by the programs, your health directors, and I think you are represented by Dr. Ruiz, who's in the Doherty. He's here today. Yeah, those are determined by the programs. Programs apply, they get awarded those funds, and virtually every health district has immunizations or other programs. I always say breast and cervical cancer program because it's such an important one, particularly in rural Georgia. The grant and aid is actually distributed. The general grant and aid, which is what's proposed to be reduced here, is actually determined by an ancient formula that I don't know really. Maybe Lee Wright, our CFO, knows. I wasn't around then. I don't know where they came up with that formula, so it's a formula-driven process based on population. And we would award it to the lead county, so every district has a lead county, and then the health directors would make a decision kind of how to. They would get an approximate amount that would go to each county, and then could have some flexibility to move it around if one county is more in need than another.
Well, for example, in South Georgia, we may have one community that has a high IV. Are we going to cut that program, or are you taking 4% off of what is already calculated, or is it per program? Are you going to look at what they're doing for mothers and babies and
No.
then what they're doing for HIV, or just here's a bucket of money? And I'm trying to understand how it's going to be determined, because again, rural communities, those dollars are very important.
Grant aid from the state comes in two separate categories. Programmatic grant aid, which is what you're talking about, the mothers and babies and the HIV,
Right.
all that comes as programmatic grant aid. That will not be reduced in any way. WIC, none of that is going to be reduced. This is in the general grant and aid, which comes really without restrictions. So it comes to the lead county and then is distributed among the other counties in the district, and the health directors themselves have a fair amount of flexibility to kind of modify the distribution of that funding. But each county, and the CFO can share with you the printout, I don't know if you have it with you now, of what each county would be, based on formula, would be allocated in the general grant need. So it's
Right. We looked at how much each county was losing. I have a list of that.
Yeah.
And that is my concern. That's,
absolutely.
For some of these small counties, that's a big bite out of their budgets, and some of them don't have other resources to go to.
And Representative Perkle made that point very clear last time, and I certainly am aware of that. But again, to reassure you that the programmatic funds will continue and have not been, we don't anticipate that they will be reduced in any way. And we're working hard to ensure we get additional federal grants.
Right.
in
The
year
same
to
thing
come.
with inspections for building to put in septic tanks, to inspect, restaurants, whatever their duties are. We need to make sure that they're still going to have the public protected.
That's my job, to ensure that continues
Thank you.
unabated.
Thank you, Mr. Chairman. I have a couple of questions since we last met with you. One of the questions, with all the focus on maternal health, has been whether or not every health department is required to provide prenatal care.
No, not required. And there was a time, I think 30, 40 years ago, when health departments did provide prenatal care. We have a group of health directors working with us on a committee to develop a template for how to do that. Some of our health directors who may still be here have prenatal care. Dougherty County does, for example. The Dalton District has prenatal care. Some is done by telehealth. Some is done actually by itinerant physicians. I don't know how else to explain that. Physicians, OBGYNs coming to provide the services, so that we don't have a single model, but we actually have a group of health directors working with our women's health team to begin a process where we can eventually, over the next several years, we hope we'll be able to provide prenatal services in every county that needs additional services.
So am I understanding that your goal is to make sure that every health department can provide prenatal care?
Or at least access. For Fulton, I'm not sure that Fulton, that's a priority for Fulton.
Okay.
I can think of other priority areas such as HIV right now in Fulton. But but say even for Fulton, we could be doing wraparound services with the OBGYNs or Grady more effectively than we've done in the past, and ensure that every child has access to Babies Can't Wait and some of the other perinatal activities.
So I wanted to congratulate you on Public Health Day. I think it's wonderful to have public health directors and see the face of who our public health directors are. Yesterday was a special day for the federally qualified health centers, and we had on our desk a map that showed the coverage of the state of the federally qualified health centers. To what extent do the public health departments work with the federally qualified health centers? I mean, it seems that we need as much cooperation in our communities as we can find.
And that really varies from district to district. I know Dougherty County, for example, is a long-standing partnership with a health center. If you look in the area of HIV, Fulton is reaching out more in that area to have expanded access to care through the community health centers. Compared to other states, we don't have as many federally funded community health centers as other states have access to, and so that's an area that I think we can do better on. But it varies from district to district, county to county, depending on the availability. But I think we're really promoting that kind of collaboration because there are some unique things that public health can do, like home visitation as a wraparound to prenatal care, which is something that we can be doing and improving mother and baby outcomes. And that's the sort of thing that we would like to see strengthened statewide.
Well, I'm glad to hear that you're encouraging that kind of collaboration. One more question, Mr. Chairman. So you touched on autism screening and contracts for autism screening. And I didn't quite understand what you said. You mentioned the Emory Autism Center and the Marcus Center, but I didn't understand exactly what you said.
There was a small reduction in the Emory contract that had to do with training. And I can get you the exact language of what that training was doing, but my understanding is that the training was duplicative, that what we were providing was not going to impact the continuation of the training or the delivery of services. And I can get you more specific data. At the Marcus Center, it had to do with this patient navigator that had been used and promoted in the past. All our staff had been trained on, but now they've moved to a new approach, and so that is no longer needed.
So the information that I got from the Emory Autism Center is somewhat different. I mean, what they are doing, as I understand it, is online training in rural communities to help with the early identification of autism in a simpler way. And what I was told is they simply would not be able to do as much training as they had been doing. So I'd like to continue this discussion with you so that we can understand what the duplication is that you have mentioned.
And I don't directly manage this contract. I'm letting you know what my program has assured me, and they were part of the roundtable that made these proposed reductions. Let me get back with you. Let me do some more. What we don't want to do is reduce services. I mean, especially for autism. I mean, that's such a critical area that you fought hard to ensure they had coverage. So
well, we know early identification is really important, and it probably doesn't take too much training to at least recommend an evaluation.
Well, we'll get back with you and do some reconnaissance.
Representative Stevens has a question, and
hit the floor. Microphone's at the top there.
Here.
In the middle.
right there.
Yeah.
Thank you, Mr. Chairman. Thank you, Dr. Toomey. I'm moving here. Focusing a little bit, we did I think it was Representative Sheldon did a bill that redistributed the formula based on population, as I recall, a few years ago, that went to the counties. I'd like to know from that point because as I remember, Chatham County lost a lot of money with the redistribution of the money, along with Muskogee and some of the others. I'd like to know where we are today as a result of this redistribution for Chatham, as opposed to the time before the redistribution, and I see he's making a note over there. But of course, thank you for what you do, because your department is probably under the spotlight, if you will, because it just pulls at the heartstrings of all of us that have to make these decisions on things that really are the safety net, if you will, for the rest of Georgia. So thank you for what you do, and we're going to try to help you get to where you need to be.
And we'll have to get back to you, because I don't have those data right with me. And just to continue what you're saying, thanks to them, the health directors, because they are the ones at the county, as I said earlier today, they're at the county levels making it happen. We wouldn't be able to do what we need to do in public health without their local leadership.
Representative Dollar, you have a question?
Thank you, Doctor. I like that you were able to maintain the funding for the SHAPE Act. I've always been a big fan of that program. I feel like it's a good investment. Can you comment on the status of it, and if you feel like it's still getting good results and it's effective? Just like to hear your thoughts on that.
What I'm actually happy to tell you is that not only are we picking up that reduction with federal dollars, we will be working with the districts so that we roll the SHAPE work into districts. And coming in as a health director, I didn't understand why so many of our programs were centered at the state without district involvement, and yet the districts are working with their schools every day, whether on an outbreak or some other flu shots for the schools or whatever. And it said this program, which can be so important to address childhood obesity, is much better placed at the district level to allow those local collaborations to occur with overall guidance and leadership from the state office. And so we're in the process of making that transition, and I think it was met with a great deal of support from the health districts who, if you asked many health directors, they didn't know what SHAPE was because they had no impact or no influence on the program. It was fully state-based, and I think the strength of public health is that it is in every county, and therefore you can develop relationships with every school district, all the local community-based organizations, all the local churches. There's much more power in those local relationships, and we are in the process of rolling that out.
I'm supportive as long as it's still being implemented, and I think it is a great investment that we can make in a lot of different ways. So thank you.
And we have a new director who is very enthusiastic. New meter.
Good. Follow-up, Chairman. As you're going through your budget, the $1,000 increase for 40 and under, you didn't have exact numbers. If we can get some information, I'd like to know how close they are to fully funding the number of employees that you have that would qualify.
But the real question is, do we have enough money to cover it? And that I don't think we can answer right now.
Yeah, I'm seeing in some other areas of the budget, like higher ed and such, that's not what's happening. So I would like to see that.
Okay.
Thanks.
Okay, thank you. Dr. Toomey, you touched on the coronavirus a little earlier, and just as we close up here, what part do you anticipate that maybe the health department will play as far as if this continues to become more of a worldwide problem, and the preparedness on your part, and are you going to have the resources to meet the challenges that may very well come to you? Could you talk about that a little bit, please?
Well, we're really monitoring this in a way that I have never experienced at my time in public health, because this is unusual. If you look at coronavirus and what it seems to do, it's a lot like influenza, and it spreads in a similar way. Its mortality rate is relatively low, but it spreads very easily. The intent of what happened this weekend is that we instituted and stood up, working with our state staff, our epidemiology staff, and the Fulton Emergency Preparedness and the Fulton EMA, a system that should someone come in from China who has been evacuated from China, an American who has been evacuated from China, we would have the capacity to either quarantine for up to 14 days following, or monitor them for the requisite 2 weeks post-exposure. What is going to happen in the future is I fully expect coronavirus, it's going to be very difficult to stop all spread. And I think the intent of this particular aggressive action is to try to stop the spread, the global spread, as much as possible, to give scientists a chance to develop a vaccine, and for us to get a better sense of the natural history of what is the incubation period exactly, and what is the contagiousness, what are the things we can do to mitigate? Are there antiviral drugs that can help, like we have for influenza? And I would expect that when this happens, when we have cases identified, the districts would be helping us monitor people, similar to what they worked with us in Ebola. To me, the real lift is going to be to the physician community and hospital community statewide. You may be in touch with them. We just sent out an alert statewide to every physician in the state. So every physician, every hospital got an alert about what the case definition is for coronavirus and what to do should you think you have a case, and how to manage that, and what are the next steps. And so I think the most important thing is not only this coordination within public health around the epidemiology, but the the absolutely critical collaboration between the practice of medicine, the hospital practice, and public health to work together to address every single case and to stop any spread from person to person once it arrives in Georgia. There's no doubt in my mind that we will have a case at some point. And I can tell you that we have had no cases yet. And we will be having the capacity to test for corona probably by the end of the week or by early next week at our public health laboratory, which will be a great asset to us because we'll be able to turn those critical specimens around much more quickly than CDC that's trying to cover all the states and all the areas of concern.
Good. Well, thank you very much. Appreciate you and your team being here with us today, and I suspect that we'll be talking with you again in the next few days.
I suspect so too.
Along. Thank you.
Yeah, thank you so much.
Yeah. Next, we're going to hear from Commissioner Frank Berry, Department of Community Health.
Mr. Chairman, thank you. And before I get started, I did want to convey to the team, 25 years ago, Dr. Toomey and I worked together in a small little town of Rockdale County, Conyers, Georgia, on an STD outbreak that was one of the largest in the state's history. And even back then, as I was probably 10 then, and Dr. Toomey was the head of public health, she came out to the county and addressed the issue with us at the local level. And her partnership and her enthusiasm for what she does has never stopped. 2 weeks ago on a Saturday, we were working together on the coronavirus memo and coordinating with other agencies, and within 2 minutes of a text, she responded. And that passion that she has never, in 25 years, has not changed. So she does from a personal standpoint, has done a remarkable job, and thank you for all that you do. I wanted her to hear that because it's really important that she gets some feedback every once in a while about that. So thank you, and thank you, Dr. Toomey. And I guess this is kind of like Ricky Bobby. If you're not first, then you're last. So I feel like, boy, it's better to be first and get out. And then I think 6 years ago, I was able to leave one time without any questions. And we're hoping for that today, but it does not look very promising. So, Mr. Chairman, members of the committee, thank you very much. It is, again, an honor to be here with you, Tara. Thank you and for all of the support that you've given. Before we turn it over to the budget numbers, and our department is a little bit different than most of the other health agencies, regulatory, compliance, and finance. And each one of our divisions is looking at ways to improve how we operate, from CON, Office of Health Planning, trying to be an office that gets people to a yes answer more than a no answer, to Medicaid, trying to help providers have an easier process of becoming Medicaid providers, but most importantly, for those individuals that are eligible for the Medicaid benefit, helping break down some of the bureaucratic barriers that historically are in place with a federal entitlement program. To SHBP, where we work with the various associations to try to do everything we can to keep the benefit package pretty robust, but the premiums pretty stable for retirees and for active members. And finally, from an HFRD standpoint, to make sure that we're doing the best we can to help people live in the most incredible places that they can live and ensure that we have high quality standards. I know Representative Petrie is one of the highest quality providers in the state, and we appreciate all that you do to keep the people that are in your care in great environments. So with that, our budget, again, because we do 97% of our budget goes out to pay claims, our budget hit was not impacted in the way some of the other agencies were, in the sense of personnel, because benefits could not be cut. But we'll be prepared to answer questions after we lay out how we addressed our budget reductions and what our 21 budget looks like. Lisa, I'll turn it over to you, and then certainly answer any questions, and I'll be here the whole time to answer any questions afterwards.
Good afternoon, Mr. Chairman, members of the committee. I'll be presenting the Department of Community Health fiscal year 2021 budget for the department. I start going by program. I start with Departmental Administration. And as you can see, as part of the slide presentation, is the first of those reductions is workload adjustments. And those workload adjustments is what is referred to as statewide changes. And those statewide changes go out to all agencies as it relates to their operations. And that statewide change includes adjustments to employer share of the teachers' retirement system, the Department of Administrative Services, security insurance premiums, GETS charges with GTAA, the Georgia Technology Authority, and the $1,000 pay raise for full-time employees who are 40,000 or below. The next item is the beginning of our programmatic changes for Departmental Administration, beginning with tracking item 17.1.5, and it's the transfer of the Medicaid funds from Medicaid low-income program to the Departmental Administration for enrollment-based growth. And what that enrollment-based growth is cost escalations as it relates to our DXC contract. That's the provider who manages our system that maintains our claims. The next one is 17.1.6, that's the transfer right from the start Medicaid program to the Department of Human Services. Those activities were transferred on November 1st of last year, and that transfer was $3,711,633. The next item is 17.1.7, and that's the federal change in the enhanced federal medical assistance percentage, moving from 86.61% to 76.92%, and that's an addition of $3,354,747. The next item is 17.1.8, and that's to reduce funds for the personal services that's projected in Departmental Administration. And that personal service reduction was part of our 6%, and that's a reduction in vacancies and the elimination of temporary employment services that we have within the department, and some contractual services, which will be the next item in terms of a reduction, is 17.1.9. And those are hourly contracts, and a couple could be the elimination of contracts in Departmental Administration. The next, we go into our other programs, and that's the Georgia Board of Dentistry and Pharmacy, and that's a reduction of expenditures there, and that's a reduction of personal services as it relates to some vacancies that they had in the departmental, in their administration function. And the workload adjustments is similar to the Department of Administration as it relates to statewide changes. Healthcare access and improvement also have workload adjustments of $4,857 in terms of statewide changes, and the 17.4.2 is a reduction in the rural health systems innovation of $463,000. Healthcare facility regulation workload adjustment is $21,938, and those are considered the statewide changes also. As we move from our departmental functions and program functions to benefits, the next slide will cover all our benefit changes in age, blind, and disabled, low-income Medicaid, and Peach Care Services. And the first of those changes is 17.7.1. It's a combination that we summed up in that line. 17.8.1 and 17.9.1, and that's the benefit growth across all programs of $89,578,629. The next item is a federal mandate in which is Medicare Part B, and those are the premiums we pay on behalf of those Medicaid recipients who also receive Medicare also. And we call those dual eligibles, and the increase for that is $18,898,667. The next item is 17.7.3 is Medicare Part D clawback, that's the prescription premium coverage that we pay on behalf of those who are dual eligible also. And for that amount is $5,229,225. The next item is in age, blind, and disabled and low income Medicaid, 17.7.4 and 17.8.3, and that's the federal medical assistance percentage for those programs. And the addition of that amount is $16,435,321. And that's a change of the FMAP going from 67.30% to 67.3%. Graduate medical education and inpatient medical education, that's an addition of $2,935,770, and that is for the go out to hospitals to make sure residents are staffed as it relate to the graduate and medical education program. Transfer, this is the same transfer that I had mentioned in Departmental Administration, and this is a transfer out of that funds going toward the enrollment-based growth in Departmental Administration for the DXC contract. And that's $3,730,520 reduction. The next item is the health insurer fee, 17.8.5 of $38,876,700 of the health insurer fee. And this is a reinstatement of the health insurer moratorium from the previous year. And this amount represents the reimbursements to CMOs for the Medicaid portion of the health insurer fee. The next is the enhanced FMAP, and this is for the Peach Care program, and that's an addition of $59,982,382, and that's for the change of the EFMAP going to 77.0% from 88% in that program. And that concludes the presentation on the benefits program. The next slide is the same slide that we have presented to you all in the amended fiscal year presentation, and it's the same general overview of the state health benefit plans showing actual 2019 with 2020 and 2021 projection as it relates to the operations of state health benefit program. I'm not going to go back.
Okay, do we have some questions for the commissioner? Well, I've got one. At least over there under the ABD and the low income Medicaid, we've got like the growth in ABD of like 101 million, of 1771. And then under the low income, 17.8.1, like a negative 18 million. Do y'all feel pretty comfortable with those numbers?
Yes, Chairman, we feel comfortable. These are the projections that we have presented to the Governor's Office of Planning and Budget during the fall, when they had requested that we provide them an updated projection on the benefits program across all programs.
Well, it seems just kind of odd that one is such a large number and the other is a negative.
For the low-income Medicaid program, the reason that there's a negative there was some enrollment decline there as it relates to Gateway last year, and there was some enrollment data that we were getting that wasn't accurate, so we had to make that adjustment as it relates to that enrollment, because different cost drivers go in related to the projection, and we made adjustments as it related to that enrollment, and that's the reason you see the reduction in low-income Medicaid.
Okay, thank you. I have a couple of other questions. Representative Taylor, I believe you next.
Thank you. Thank you, Mr. Chairman. I have a couple questions, and I'll start with 17.2.3. It's reduced funds to reflect projected expenditures. Okay, you're going to reduce what you're spending. What kind of things are you not going to use for expenditures?
That's for the dentistry and pharmacy program.
Right.
Those are actually positions.
Those are people.
I'm not going to say people, I'll say vacancies that they had on the
Okay, and you're just not filling, you're not firing anybody, you're just not going to fill that position. Right. So projected expenditures, sometimes it means people, sometimes it could mean something else. But underneath it, it says workload adjustments. Now, is that taking those positions and those jobs, those tasks, and putting them on someone else, or what does workload adjustments mean?
Workload adjustments are those statewide changes I referred to.
Yeah.
So that's like GTA costs that might be going up, the insurance premiums at DOAS, and these are changes that the Governor's Office of Planning and Budget put in for all agencies related to some across state agency changes. And let me tell you specifically.
Can you give me an example?
Okay. For one of the reductions, that's a sum of that reduction. One of the reductions is GTA administrative fee for the GETS contract, which we have to pay into as it relates to maybe telecom and those type of activities that occur. So that's an adjustment that's in that number. Also, that's in that number is cybersecurity insurance that we have to pay to DOAS. That adjustment is in that number also. And those are what operational adjustments, but not related to people.
Okay, so then another one on 17.4.2, reduce one-time funds for the Rural Health Systems Innovation Center. Where is the service or what they're doing? Where's it going to go? That's not something you could workload. This is a relatively new program for rural Georgia.
So that's at Mercer University, and we're in discussions with Mercer and OPB right now on what was considered startup funds, what were considered ongoing base funds. So that's an ongoing discussion, but right now it is a cut.
It's a cut, so that those funds are not going to be available for the Innovation Center to work on programs. In this case, it was
a reduction of $463,000.
Is there other dollars, or was that the total amount they had?
The total that was appropriated to that, if I'm remembering correctly, is $1,362,000.
Right.
So that amount will be reduced by the 463.
Okay. And do you know how it's going to be reduced? What they're going to do away with people, programs? What are they going to do with that reduction? They're not going to get it.
We're in discussion with them now and don't know yet.
Okay, thank you.
Thank you, Mr. Chairman, and thank you, Ms. Walker. You're always such a competent and capable presentation, so I appreciate this. I have a question, and it's one that I spoke to previously. We were talking about the little budget. There's nominal cuts to healthcare facility regulation. And there's some increases here for those that are, it looks like there's probably very few people at HFRD in the less than $40,000 range, right? Is that fair? I'm looking at some of your staff over there. Because we got a little bit of money there. I guess those are admin staff. assume. So, but in previous testimony, what we discovered was that there is an acknowledged shortage of surveyors for skilled nursing facilities. And I want us to talk about that, because here's what happens up here. We've got a lot of bills flying around this building, and as we always do on a little bit of everything from A to Z. But there are always people that want to pass new regulations on everything, on skilled nursing facilities, on assisted living communities, on this group, on that group. That's okay. Can have those debates. But I'm a believer that you first and foremost have to enforce the rules you've already got and the standards you've already got, and we got to make sure that we're doing that. And there's a lot of folks that are skeptical about making sure the department has the resources they need. So I think you know me well enough to know what I want is make sure the department has those resources. So your department has acknowledged that we have a difficult time with hiring and retaining nurse surveyors for skilled nursing facilities. First of all, is that fair to say?
Yes.
Okay. So why do we not have a request here? You know, we've got money in here to raise admin staff up. Why aren't we looking to make sure that we're adequately paying nurses needed to survey skilled nursing facilities so that we can have the best and the brightest in this state doing such an important job? Again, as you know from my previous questioning, I'm always going to come back to the same thing. I want to know that we're taking care and protecting our folks, and I'm all for any cuts that relate to efficiencies, because quite frankly, that's what the private sector does every day, all day long. So it doesn't hurt my feelings that we're cutting things that need to be cut. However, what the private sector also does is make sure that if you're going to retain the best and the brightest, you have to pay them fairly. And so so if you could speak to that, I hope that we could be fully staffed with surveyors, whether it's for child care or personal care homes or assisted living communities or skilled nursing facilities. We should first and foremost know that, because the industry wants to be regulated. The industries, plural, want outlaws removed. So we want to make sure that HFRD has the resources, the tools, whether it's technology or whether it's manpower, hiring the best staff. Nobody can hire nurses anymore, so obviously that's driving everybody's wage up for hiring nurses, and I know you'll hire a lot of nurses in with those surveyors. So help me to understand why we're not looking to fix that issue if it is indeed an acknowledged issue.
Yeah. Thank you, Representative Petrie. And your support over the years has been incredible, and everything you've said we're in agreement on. So a couple of things. If you remember 2 years ago, we came before you with an emergency request to boost up the funding for nurses in HFRD long-term care, and you all very, very quickly supported the department, and we were able to move from, I believe, $50,000 to $65,000. And for the first year, that really had a significant impact. We were pretty much running fully staffed, and things were moving along pretty well. What we found, what we have to determine is it the work environment, and I think you'll experience this too at times, is it an environment issue or is it a pay issue? And so we're doing work right now internally with our Office of Human Resources to figure out is the workload that we're asking these people to do manageable? What's the work-life balance? And are we asking too much of our team members? And is that impacting our vacancy rate? Because we are down nurses right now. So we have openings for nurses. We can recruit. We have a difficult time retaining. How do we balance that? And so we wanted to do a very, very thoughtful analysis of what's going on, because I think you can, using y'all's term, go to the well sometimes too often. Not that I'm at the well, but go to the well too often, and then people start to say, well, gosh, they always just come here with a hat in hand asking for more money. We need to make sure that what we're asking for is what we need. And we're in the process of doing that thorough evaluation right now, analysis now, so that we can come to you more than likely next year with what our concrete ask is that we believe can help solve our vacancy rate. On the long-term care, if we have vacancy rate that we're currently experiencing, it will cause us problems. You are 100% accurate. It is going to cause us problems with keeping up with those. But I don't know. What I don't know definitively, is it just money, or is it how we do our surveys and everything else? From a regulatory, and to your point about the regulatory compliance, we're looking at, and that's where I conveyed last week, we're working with the trade associations. We'd like to work with as many members who have an interest in this as possible to get insight. What makes the most sense from a regulatory compliance? You're right. We don't want to be over-regulatory, but I think there's an argument right now that we're under-regulatory. We don't necessarily, we're not digging our heels in. We want to hear from people, including you, including others, what makes sense from an industry standpoint, and then what can we do as a state that we can follow through on that? Because I think you could put a bunch of stuff on from a regulatory compliance standpoint. It's similar to in the department that I used to work with. You could set up these teams of people in South Georgia, and the team sounded wonderful, but there was no way that you would ever be able to recruit for the team members that were supposed to make up for that team in certain parts of South Georgia. I want to make sure that what we're doing from a regulatory compliance standpoint is reasonable, but provides for number one priority. And out of all people, you preach this to your team. I've met with your team. The health and safety of the individuals that are entrusted to our care is our number one priority. How do we make sure? How can we wake up the next morning, look ourselves in the mirror and say, and I can look my children in the eye and say, I'm doing everything we can. We've got to have those discussions.
Commissioner, that's a fantastic answer. You've sold me. Thank you.
If you're not first, you're last. Ricky Bobby, again. Thank you.
Thank you.
You're
Commissioner, talk to us a little bit about this wellness, I guess you call it Share Care app and state health benefit, and what's going on with that, how's that working? Is that making us all a little healthier and so forth?
Thank you for the question. And we have several of our team members here. Jeff Rickman is here, who is our executive director of a state health benefit plan. We have Blake Fullenwider, chief health policy, Joe Hood with regulatory compliance, so I may call on them to ask. But the Share Care, so when I started in the department 3 years and 2 months and a couple of hours ago, we had a company that his name was Healthways that had been the wellness provider for the state of Georgia for some time. ShareCare actually purchased that company, and so that's how we partnered with ShareCare. I'll back up to 1986 when I worked for the school system in Florida, and then in 1991 for a rural community mental health center in North Carolina, and then finally in Georgia in 95 with a variety of different, all public service, with a variety of different public service agencies, including a stint with the Department of Juvenile Justice where I did my time. Every one of those entities had a wellness platform, a wellness program that people would go and do a biometric screening, get your blood pressure checked, check for diabetes, and here's $25. And that was about it. When I came to DCH, there was a tremendous amount of frustration from members and members of the General Assembly, along with constituents who said, can't we do more? We want to do more to take ownership of our health care. And we heard that from retiree associations. We heard that from active members in the state health benefit plan. How can we do more? And so right at that time is when ShareCare purchased Healthways. So we started to have those discussions, and what we discovered, didn't know a whole lot about ShareCare, was that they were in some regards, the world's leader with a digital platform for healthcare, wellness plans. And so that was what we were interested in. What we heard very clearly from people in rural Georgia was that they felt very disconnected from what goes on in Atlanta. Well, how do you connect? So they presented that they have this app that you use to be able to track your stuff. I kind of have looked at it as a Fitbit on steroids. Now, probably the wrong word since it's a wellness platform and steroids aren't good, but as a Fitbit on steroids, because what we see now in the various departments, and the departments have come together to talk about this, a lot of departments, you now see people who are at water coolers talking about their app and did they meet their goals today. They're talking about their health care. And then they get their benefits and all those things. Jeff can talk more in detail about that. But what we're starting to see, remember, we're not that far into this partnership yet. What we're starting to see is a movement of people who want to have ownership of their health care. The older people that are in our plan are very, very actively engaged in a diabetes initiative that they do, and it's where they can interface with other people on this app. So we're trying to give people an opportunity we're trying to demonstrate that we value our team members and we're willing to invest and give them an opportunity that a lot of private industry has, that historically the state hasn't done a real good job on. And so that's kind of the history of it. And we can get into more details, and Jeff can talk more about that. But I hope that helps a little bit.
Thank you. Any other questions from committee members? Yeah. Representative Taylor.
Thank you, Mr. Chairman. I know we've had these discussions before with our ABD group, and is there a way, would it improve care as well as cost efficiencies if we looked at a managed care program? Or are we hampered by federal dollars? Or I have concerns because that area of population is growing and their expense is growing, and we don't seem to have any control.
So we've had a little over a dozen years experience with managed care for children. Mm-hmm. And I think that when you have to think back historically. I think if we don't look back at our history, it's hard to make an informed decision for the future. So if you think about when managed care came in for children back in, 2005, whatever year that was, we had out of control Medicaid spending that we just as a state could not keep up with. And we were in the beginning and middle part of a tremendous economic downturn. We had to get control. So the overall emphasis of bringing managed care, and now this is the world according to me, and I was a provider then, was control cost, control cost, control cost. We had to do it. Over the last dozen years, now what we're experiencing is, yes, we need to control cost, but now the question becomes, at what cost? Mm-hmm. Are we getting quality? And so we are now working very closely with all four of our current CMOs on how do we demonstrate that we're no longer just focused on dollars, but we are very, very focused on the quality of care. So to answer your question specifically, nationally, we recognize that most states have gone to some type of the management of care. And Georgia has been, whether it's this department or whether it's Commissioner Fitzgerald at DBHDD or Public Health or whoever, have been preparing their networks of providers for some type of management of care in the future. We understand that we need to prepare that. I think there has been a significant amount of lessons learned from a contractual standpoint, from a performance-based contracting and everything else that can help inform what that looks like if the governor decided to move down a managed care plan. Remember, we're like BASF. We don't make the policies, we just enforce them or make them better. That's a decision that is much larger than just a commissioner of a Department of Community Health. If the state of Georgia decided to go that way, we would be prepared to do that. And there are some great lessons learned from the children's programs that could help inform and make that a strong program.
Well, you know I have concerns about some of our general managed care programs, and there are issues with them. I do see it as a potential savings, but more than that, I'm looking for coordination of care
Yes.
for better outcomes, and I don't know that we're getting them now, and I don't know that what we do always in our other programs is exactly the right fit either.
Yeah.
But at least I know there's discussions of it, so that at some point in time, we can find the right mix for something that will work for all.
Yeah, and you bring up a great point, because we are now in formal discussions with senior leadership of the 4 plans about service coordination. That's an area where we're all in agreement that if you strengthen service coordination, you will see better outcomes.
Right.
And we're excited about that work. They're, at the table with us. And I think that we're going to see some positive outcomes of that work in the next, more than likely, several months that I think we'll all be proud of.
Thank you.
If the governor asked your opinion or the department's opinion on moving ABD to a managed plan, what would your response be?
Very similar to what I just said.
I couldn't hear you, so would you repeat it? I'm
Yes.
sorry.
I said that we have been preparing for some type of managed care environment.
I heard that part.
Okay. And so my response would be, if the governor asked my opinion on that, I would say we have been preparing, and if that's a direction you would like for us to go, we could indeed move down that path. But there would be some lessons learned from the children's side that we would absolutely feel we need to make certain are addressed if we move to the adult population.
In your estimation, is the children program under managed care working very well?
I think it is working in the sense of controlling some costs, and I think we are beginning to move in a better direction in looking at quality. But it's not where any of us feel we need to be right now.
With the fragile population of ABD, is that a good place to look for cost savings, you think?
I think it is with proper contract management and with looking at what your expectations are in regards to overall health outcomes. I think that you can get there, but it is certainly a population that we need to be very, very, very cautious about.
Have any states stepped into that and then stepped back out?
Yes. There have been states that have stepped in and stepped back out on the ABD population.
So we would be prepared to do that ourselves also, you think?
Step in and then step out?
If need be?
I think, again, with some of our lessons learned and with the right oversight, we could be successful if that's a direction that we were asked to go. I also think that there's opportunity for us to continue down the path that we've been down and look at how we can do a better job controlling cost as well.
Sounds like a good idea to me. Thank you.
Thank you. I want to remind everyone that we have another meeting. It's going to be taking this room at 3 o'clock. So we want to move right along if we can, and we'll have the opportunity next week to get into some more of this that we didn't get to cover today. So, Commissioner, thank you.
Thank you very much.
Lisa and your staff and team for being here. We appreciate the information, and we'll be in touch.
Thank you. Thank you, members.
Okay. Next, and our final presenter today, Lashon Hughes, the Executive Director of the Georgia Board of Healthcare Workforce.
Popping in.
If y'all would, close that door in the back for us, please, so we could hear, and we'll move right along.
You need to.
Go ahead, Lashon, we're ready.
Okay. Thank you, Mr. Chairman and committee members. We thank you for your support of the board through the years. He's trying to load the presentation, but I think you have copies. We are displaying our original budget for 2020, get my glasses, 82.4 million. Then we'll go, here we go, third page. So our first program is 17.11. So we have statewide changes under 17.11.1 for $4,857. 17.11.2 recommended reducing personal services for $80,000, and that is a vacant position that we have. It doesn't cut anyone that's current. 17.11.3, a recommendation is to reduce telecommunications, and the total recommendation is $1.1 million for administration. We move over to graduate medical education. 17.12.1 is the recommendation is to increase funds for new residency slots in primary care, and 17.12.2 is an FMAT reduction. 17.12.3, it's reducing funds from the accelerated track program at Memorial Health. 17.12.4 is reduce funds from statewide residency medical fare for $40,000. 17.12.6, a recommendation is to reduce funds for contractual services to reflect projected expenditures. 17.12.7, and reduces funds for fellowship at Augusta University. 17.12.8 reduces funds for startup grant for South Georgia Medical Center, the residency program, which was provided in FY 2020. 17.12.9 reduces funding for rural surgery initiative at Augusta University. 17.12.10 reduces funds for child and adolescent psychiatry slots from Augusta University. 17.12.11 reduce funds for Augusta University for a 3-year primary care residency track, which was provided for in FY 2020. Our next program is Mercer School of Medicine Operating Grant. 17.13.1, the recommendation is to increase funds for operation at Mercer University. 17.3 for the Columbus campus. 17.13.2, reduce funds from the operating grant, 1.4, and our total recommendation is $23.4 million. Morehouse School of Medicine Operating Grant, 17.14.1. We're reducing funds for the operating grant, $1.7 million, and our total recommendation is $27.1 million. Physicians for rural areas, these are our loan repayment programs. It is labeled physicians, but we do give loans to dentists, PAs, and APRNs. We're doing a 17.15.1. The recommendation is $500,000. 17.15.2 is reduce funds to eliminate the malpractice insurance premium. And our total recommendation is $1.7 million. Undergraduate medical education, 17.16.1. The recommendation is to reduce funds for marketing and outreach for Philadelphia College of Osteopathic Medicine. I think that was a one-time funding. 17.16.2 is reduce funds for medical student capitation for all of the medical schools, Emory, Mercer, Morehouse, and PCOM as well. So the recommendation is $3.5 million. And this is our total budget for all of our programs across the board, with a proposed cut of $1.7 million. That's it, Mr. Chairman.
Okay, any questions from the committee? No question? Okay. Well, evidently you did a good job of explaining that. Thank you.
Thank you, Mr. Chairman.
Oh, I'm sorry. Excuse me, I didn't see your light there. Representative Hughley, go ahead.
Thank you, Mr. Chairman. Thank you for the presentation. On your 17.12.7, the fellowships that you're reducing, how many students are we going to affect when we do that?
17 point, I'm sorry, what was the number?
17.12.7. This is at Augusta University. How many students does that represent?
So I think it was 3 fellowships that they were starting. It's new. It's a new program that hadn't started yet.
Mm-hmm. So all of those cuts were just all the new stuff?
That was one of your initiatives that you put in there recently.
I know. And then I also was concerned about the 17.15.1, the loan repayment awards. How many students are we affecting there?
So our original count, this was also new funding put in last year. It would have been 13 additional physicians, 10 APRNs or PAs, and 3 dentists.
Okay, thank you.
Okay. Any other questions before Representative Gardner?
Chairman, I'm just curious, on page 5, there were a number of the recommendations that we made last year that we thought were really going to be helpful to our healthcare system. What are you telling us, that all these people did not initiate moving forward on the appropriation? I mean, how is it that they can now take this cut? They hadn't started up any of the...
They had not started. So those were new initiatives that was put in last year. Although I'm sure, I know for a fact that Augusta University had made plans to get started on some of these programs.
So they had made plans, but they hadn't hired anybody or contracted with anybody. Is that what happened?
Not that I know of. We could find out for you.
Representative Taylor, go ahead.
Okay. It's just, this is disappointing. A lot of these are items that we've put in, again, emphasis on rural health, but these are health providers that are needing for all of our underserved medical communities. And for me, one of the things that jumped out was the PCOM. They're adding, and they were in South Georgia. It was wonderful to get a medical school in South Georgia. Have you discussed with them? Do you know if they're going to change their plans, or they're going forward? They're there, they've built a building, and now we're pulling back funds that we've already told them they were getting. I guess that's where I'm going. Do we know how any of these folks are going to react to this?
We did reach out to everyone and get impact statements from all of our programs, and we have copies that we can provide to Tara to send to everyone. So when the budget cuts first came down, of course, PCOM was the first person in the office because of their new campus. They would like to go forward, but they would also like to not have their budget cut like everyone else. Yeah. So that we can provide the committee with impacts, some of the impacts.
I would like to see that, if you could give us the impact, how each one is going to be affected, and what funds are still going to be available, if any, for some of these programs. Thank you.
We can certainly do that.
Great. Thank you very much, Lashon.
Thank you.
I want to thank the committee for being here this afternoon, and thank the folks in the audience for attendance. I want to remind you that tomorrow at 1 o'clock in this room, we'll have a public hearing regarding the FY 21 budget and have an opportunity to have public comments on that, 1 to 3 in this room. There'll be a sign-up sheet here about 15 minutes before the meeting starts. You'll need to sign up if you'd wish to be heard on that. And then we'll do that tomorrow, 1 to 3 in this room here, 341 at the Capitol. And then to the committee members next week, expect to, we'll be getting together to look at some more information and be talking with the departments as we go through this next week.